So let's quickly look over the importance of factor 10A. So a lot of the thrombin activity in terms of the coagulation cascade is really going to be dependent upon factor 10A specifically. And that's because factor 10A is really responsible for converting prothrombin, which is factor 2, to thrombin, which is factor 2A and biologically active. And then we said thrombin, or factor 2A, plays really major steps in the final role, or the final steps in the coagulation cascade, but it also has systemic effects, as well as local effects on the vasculature, and as well as promotes inflammation. So there's another kind of sub-classification scheme you should be aware of, and really this kind of relates the ability of these drugs to, one, inhibit factor 10A, but then two, what they look like structurally. And so fondaparinux is really a factor 10A inhibitor that looks like heparin. It's also known as a synthetic heparin-like molecule. Remember, heparin comes from animal mucosa, and it's harvested. Fondaparinux is a synthetic molecule that's made in a laboratory, but it acts pretty much like heparin in terms of its mechanism of action, with a much higher affinity towards the factor 10A antithrombin interaction than the factor 2A or thrombin cothrombin interaction. Another group of drugs include the factor 10A inhibitors that look like low molecular weight heparins, and so the prototype here is the trade name enoxaparin, or the brand name Lovenox, you've probably heard. This is one of those low molecular weight heparins, which also has the ability to, remember, inhibit factor 10A, but also inhibit thrombin. I know this literature is crazy, but again, just look at those summary charts and it'll make more sense. And then there's the factor 10A inhibitors, which are kind of like they're called newer oral agents. They've been around, God, maybe 10 years. So they're not really new anymore, but they're new relative to heparin. And that's the rivaroxaban and apixaban. And you've probably seen commercials recently for these two. They tend to advertise quite heavily. So let's look at fondaparinux. And so fondaparinux selectively binds to antithrombin, which leads to the inhibition of factor 10A. And we said earlier that this was a synthetic molecule, and it really has no effect on thrombin, or factor 2A, but it increases the activity of antithrombin by 1,000-fold. So it has a much higher affinity for that antithrombin factor 10A interaction. And by inhibiting factor 10A, we're going to reduce the effects of thrombin. We won't affect the actual activity of it, but we'll reduce the effects of it because not as much of it's going to be made, which is going to severely restrict kind of the growth and the production of a larger platelet. Interestingly, it has no effect on the function of platelets that are already out there because it's essentially leaving the factor 2A, the thrombin molecules alone, the ones that are already activated. The clearance of this drug is primarily renal, so patients that have altered renal function may need a little bit of a dose reduction, and that half-life is about a day in patients that have normal renal function. Now, of course, if they've got reduced renal function, that half-life can go obviously a little bit longer. What's good is that the anticoagulation effects can last anywhere from 2 to 4 days after the patient discontinues the drug. So this is great for instances where you know that the patient is going to undergo a specific procedure, even a minor procedure. You can have them stop administering the drug. And remember, this is sub-Q, this isn't an oral tablet. You can have them stop administering the drug a couple days before a procedure and then go back on it quite easily after the procedure is over. And as the last point points out, it's really useful for patients undergoing joint replacements, and it's more recently been FDA approved to actually treat DVTs and pulmonary embolisms. So it's quite a good drug. The other drug in this class of factor 10A inhibitors include rivaroxaban, and this is a selective and reversible inhibitor of specifically factor 10A. Okay, and the indications for this include, as I said before, venous thromboembolism, prophylaxis for blood clots during joint replacements, and then the newest indication is atrial fibrillation. And so we didn't really talk about this drug in the AFib case because it's kind of the newer version or the newer indication in terms of basically managing the coagulation. Um, First and foremost is in terms of popularity is Coumadin, but you can expect probably within your professional career, and I suspect too that rivaroxaban will probably start to replace Coumadin, especially for the AFib patients. There's been a trial or two that's shown it to be quite clinically efficacious, and you don't have to do INR monitoring with rivaroxaban like you do with Coumadin. So in terms of patient compliance and patient management strategies, it's a lot easier. The dosing is listed there, and then there's a specific dose guideline for atrial fibrillation. You don't need to know the dosing, of course. I don't really ask you dosing on these exams. It's just kind of there for your for your kind of general knowledge. Understand that in the AFib patient, the dosing is based on creatinine clearance. Okay, rivaroxaban is also associated with many drug interactions, as is Coumadin. So you don't really eliminate that management strategy or management problems. There's a strong P-glycoprotein interaction, and there's a strong interaction with other drugs that are utilized by the CYP3A4 enzyme system, specifically the inhibitors. The outcome here is that you get increased rivaroxaban exposure, and so the specific drug-drug interactions are listed there. And of course, with patients that have moderate even to severe hepatic impairment, you definitely wanted to monitor them a little bit more closely. Another drug in this factor 10A inhibitor category is apixaban. This one corresponds to factor 10A, and it doesn't affect the existing platelets. This is orally administered, which is a little bit better, especially for patients excuse me, who don't like to self-inject. You can see this used for reducing strokes in patients that have had systemic emboli. You can also see them used in patients that have AFib as a result of non-valve type pathologies. And of course, it's really common in DVTs, prevention strategies for patients undergoing joint replacements. And it's also been used as the drug before it to actually treat deep vein thromboses and pulmonary embolisms and then prevent their recurrence. And so you can see patients that have had, and we'll talk about this in another chapter, but you can see patients that have had a pulmonary embolism will be on some type of anticoagulation therapy anywhere between 3 to 6 months, depending on who you read and what part of the country you practice in. Excuse me. So that basically finishes the drugs that are in the factor 10A inhibitor category. So we'll end here, and then we'll pick up in the next segment.